So, for those of you who don't know me, I am Dr. Monica Bhaskar, who is presently an assistant professor in PS Medical College, Kuppam. Some of my PS postgraduates have joined and they know about me. So, my main agenda for today's demo class are two things. One is to introduce to all of you about this online course. So, what made me think about this online course and what is its use for you people? And the second thing is the type of sessions which I will be dealing with in future in my course. Okay, so let's see what's in store for us today. So all of you might think, why this course? Why should I join an online course? So I got many concerns telling, ma'am, how is it different from other course? Why should I join your course? Is there study material available? Well, the recordings are there, or do you provide any learning material? Is offline video accessible? So all these questions are popping out on my message screen daily. So I wanted to make it clear about what is this course and what we'll be having, and what is, if you enroll, what are the benefits of this course. So firstly, what made me choose to do an online course? So many of my postgraduates and some of them from Bangalore when I was working in BMC, they were asking me which book to study. Should we study books, or should we study guidelines, or should we go and subscribe to any other platforms where there are recorded videos, and should we make notes out of it? So all these questions are my, like, every week I get these sorts of messages and they call me in person and they ask. So I was like, okay, let me think about something, and so that it is easily available for the postgraduate, so that I will be like a mentor for you and tell this is important. These are the must know topics in your post graduation. And obviously, there is a lot of syllabus to deal with. And presently, people think that, okay, let's go and just pass the exam. And after PG, I will go and read Till India, I will read Spiroff. But that is not possible. So I thought, okay. And as most of you who know me, they know me that I have a good passion, and my passion is for teaching. So I thought, why not attempt this and start an online course so that it will be beneficial to the PGs, and it will give me some kind of happiness and high after I do a class. So post graduation. So I've put some of my pictures thinking that these are the same things which you people are dealing with right now. So you people are busy in labor room, you're busy in OT assisting surgeries, you're doing night duties, and you are tired, and you don't know when to study, you don't know what to study, you don't know how to make a timetable. So all these are there. Post graduation as gynec specialty is the most busiest branch in the hospital. I know you people have a tough schedule to deal with, and you're always busy. But you have something in mind that yes, we have to study. But when to study and how to go about it? So that is the difficulty of post graduation. But I will tell you, out of my personal experience, this is the best time to study. So once you finish post graduation, if you think that I will study after it, I will refer reference books, I will go and study guidelines, you might study, but you might refer. But it is not that easy. But post graduation is like a foundation for a tall career. So if you want to build a building, so I my you might have seen your parents telling your foundation should be good, your foundation should be good. So undergraduation and post graduation is like a foundation to build your career. So in future, whether you're dealing with clinical practice, you want to become a laparoscopic surgeon, you want to become a fetal medicine specialist or an infertility specialist, that is secondary. But to be an obstetrician, you have to have sound knowledge. So I want to highlight one quote, that is, what the mind doesn't know, your eyes will never see. And learning is a continuous process. So it is not attained by chance. It should be sought for with order and diligence. This is the quote which I believe it. And it's a lifelong process. It's not that I finished learning now, I finished my post graduation. It doesn't mean that I don't study today. So today also I have to refer something. I have got a patient I have to deal with. So it will be a higher level of study. But what basic study you have to do, you have to do it with your in your post graduation. Next, now you have made up your mind. You know that post graduation is a difficult process where you have to invest your time, you have to make time. So now you have a schedule, You have made up your mind. You have squeezed some time to study. What to study? So as I told you, many of my graduates or postgraduates or some of my interns tell madam what to study. So this is the picture which I've taken from my own study cupboard. That is my bookshelf. So these are the different sources of books or books which are available for gynecology. So these are very less. I have still more, but I had to squeeze in to put it in this image. So the sources to study are textbooks, reference books, guidelines.
నిన్న చేయిస్తుంది మండే ఒకసారి ఫైనల్ గా
Go and refer for RCOG guideline, whether to go and refer for ACOG guideline and other things, or whether to follow what is done in your hospital. So you will be like, madam, why to study all these topics and things from textbook? I will just practice what they do in my institution. I know how to manage a preeclampsia case. I know how to manage an fibroid uterus case. Why should I open the textbook and see? I know my institution is there. I am learning case based. That is out of clinical experience. Yes, that is very much true. But what are we doing in an institution should be evidence based. So I am a personal believer of evidence based medicine. You might wonder, what is this evidence based medicine madam is talking about? This evidence based medicine is doing the best to the patient based on the current evidence which is available. So these guidelines and things have not come just out of it. It's not just like a hobby where they release a guideline. They have put in a lot of efforts to do studies, meta-analysis, reviews, Cochrane reviews, and they've piled up into a guideline copy for that, for us to refer and do the best what we can do to the patient. You might think this is the best what I know and I'm practicing, but it is not like that. If out of your ignorance, if you're doing something, it is definitely harming the patient. And in future down the lane, we will be liable to various medical legal complications. And that time, if a patient or an attender comes and asks you, why did you manage like this? You have to have a valuable answer telling, this is my reference, this is the management, and I am doing what is called as evidence based medicine. And one of my professor, when I was PG, used to always highlight on telling PG is discovering the question why. So in UG, you might have thought magnesium sulfate is a drug of choice in eclampsia. PG is discovering why you have to give magnesium sulfate. So that is a small example. So LNG-IUS is the drug of choice for AUB as a first line. That is a UG knowledge. In PG, you have to know why that is used. Why not histamine? Why not other progestrogens? So you have to understand what is the importance of why in each and everything you're dealing with. So if you want to manage something, you have to ask yourself, you have to reflect. That is called as a reflective practice. If you have done some management or you've done some surgery or you've done some study, you have to go back and ask yourself, did I do it right? Why did I do it? Is it the right answer? So PG and post graduation is just about discovering the answer for why. So this was the background of why you needed a course. So now you have made up your mind. You have thought, yes, I will study and make time. Now you have to know what to study. So this is a platform of a course where you can know what to study, from where you have to study. And if you ask me how this course is different from other courses, see, you might have different platforms where they have recorded videos and some study material. So that is also a good the source of knowledge. You can open the video, you can listen, you can make notes, and you can listen, but that is a lot of self motivation. But if you join this course, I will be the one who will be motivating you now and then, and it will be live classes where we can interact. So that's why I am not taking a lot of students. It will be a limited enrollments which I am considering, and it will be a live interaction. So we are dealing with one topic. So at the end of the session, so if the session lasts for about 2.5 hours, the last 30 minutes, we can have a one-to-one discussion. So if you have a doubt, you can unmute and ask, madam, this is my doubt. And the other people who are also enrolled, they will also get clarified. And if you don't want to ask in the meeting, you can ask me on WhatsApp, or you can call me. So it's a live interaction and you have a one-to-one connection. So it's like if I've enrolled 30 students, if I've enrolled 40 students, or if I've enrolled 5 students, you are like my students whom I will guide you throughout. And that doesn't mean that I will be the person who is writing your exam. I will be the person who is guiding you throughout, but you have to make that effort from your side to study, to participate, to apply it in your clinical postings and in your future career. Okay, so what is this course about? So you will be getting a schedule per month. So we'll be creating a WhatsApp or a Telegram platform based on the enrollments, and a monthly schedule will be put upon in that group. And every week you will have 2 to 3 classes. So those who have enrolled for a long course, you will have around 3 classes per week. And those who have enrolled a short course, you will have around 2 classes per week. So what are the other 4 days in the week for? So other 4 days in the week are for self-directed learning. So you might be wondering what madam is speaking self-directed learning and all. 2 days back, I attended a course called as basic course in medical education. So they really emphasize the importance of self-directed learning. So that means I will be the one who will be giving a timetable. These are the things you have to cover. 1 second, rifle. So these are the, sorry, this is my pet. Okay. So you will be the one who have to go back and see the schedule and check for what to be done. And that timetable will be given to you. And 4 days in the week is for self-directed learning. It's not that you go to the library and keep on studying. That is not self-directed learning. There should be a proper timetable, and I will be telling you what all are the related topics you can finish in that week. So, for example, if we have dealt with hypertensive disorders, if I have dealt with preeclampsia, I will ask you to read about eclampsia and other complications of preeclampsia, so that the entire HDP topic is over in 1 week, so that you can revise it during your exam. So, that is the planning which we will do per week. And what are the different types of sessions which will be available? So there will be 3 kinds of sessions. So who have enrolled in a long course, you will have 3 kinds of sessions. One is a case-based learning. Means, for example, a patient is come with AUB. How will you manage? Basic history. What are the examination findings? What is evidence-based medicine tell? How will you manage the case? And the second will be absolute theory lectures about what is the theory and how will you clinically apply it to. And the third one will be practical case presentations, which will be helpful for your final practical examination. So if you have enrolled into a short course, you will be only dealing with practical case presentations. And I've shared you the long course curriculum and the short course curriculum. In the short course, there will be 12 obstetric cases, 8 gynecological cases, and 4 mock stations at the end. So we'll be dealing with 24 sessions, but for a long course, you will have all theory lectures as well, and case-based learning will be there. And as already mentioned, we have to we'll have a clarification of doubts at the end of each session. And the learning material like guidelines and any other my notes or some important take home messages, such things will be shared on that group which is created after the final enrollments. And after the end of the course, if you have any extra sessions to be taken, or you have any extra topics to be covered, we can do it at the end of the course and at the end of the curriculum where we have finished all other topics. And finally, we'll have a final exam paper distribution. Like you all know, there are 4 papers which you have to be attending. One is the basic courses. The second paper will be obstetrics. The third paper will be gynecology. And fourth paper will be recent advances. So I have cumulatively made an folder for each paper and the topics which are usually appearing in each of the papers. And that cumulative thing which I have made during my PG and post PG all these years, I will be sharing it to you at the end. So this is a brief note of how this course would be. And enrollment into this course is like having a timetable in hand with a mentor to guide. So this is the only statement which I have to be telling you about the course. So next, so the other 20-30 minutes, I will be doing a demo class for each of these, which I've mentioned before, a case-based learning, practical case presentation, and a theory lecture. So you will know what you're enrolling to or what you're taking up to. So you will understand how this course would be going to. So each of this 10 minutes. So I will, the main motto of me was not to take an entire, see, I did not want to cover the entire breach presentation, because that is the, if you type a YouTube video telling breach presentation, so you will get, so for about 2 hours. So I did not want to do a demo class based on the entire topic that we will be actually doing it in our lectures in the course. But now I wanted to brief out on how the session would be. So I will just do a 10 minutes problem solving and case presentation or theory. It's like a trailer between before an actual movie. So let's go into the second part of the session. I hope I am clear. And if anyone has any other doubts regarding the course, if you have any other things to ask me, you can unmute and ask. Otherwise, we will continue to the subject proper. So, shall we continue? If yes, I can continue. One of you unmute and tell
Yes,
me.
ma'am, we can continue further.
One second. Okay. So now this is a demo of problem-based learning. So what is problem-based learning? So if you see an antenatal woman or a gynecological woman with a problem or a case-based learning, it's also called as case-based learning. So they come to your OPD with some symptoms. Sure. So how do you go about it? So I have chosen a topic called as PPROM, that is preterm premature rupture of membranes. So what is my case scenario? A 28-year woman, so that is Geeta, has come with, she's a primi gravida with 29 weeks of gestation with leaking per vagina since 4 hours. So this is a chief complaint with which the patient has come to you to your OPD. So how do we go about this case? So let's discuss what are the brief history you will ask. How is it important to arrive at a diagnosis? What are the examination you have to do to confirm your diagnosis? And what relevant investigations which has to be done? And finally, how will you manage the case of PPROM based on current evidence? So as I told you, she is 25 years with 29 weeks of gestation and visited your OPD with leaking per vagina. The first thing you will ask is from when she has noticed her leak. So she's telling that she's noticed her leak since 4 hours. So what are the next histories which you will elicit? So first you will ask her whether she has any pain abdomen. So why pain abdomen is important? You have to differentiate between preterm labor and preterm premature rupture of membranes. So now you have to know what is the definition of PPROM. So it is a spontaneous rupture of membranes before the onset of true labor pain after 24 weeks of gestation and before 37 weeks of gestation. So each word is important. So what did I tell? So it is before the onset of true labor pain. That's why you have to ask her the history of pain abdomen. So she tells, no, I don't have any history. I just have leak per vagina. So she doesn't have pain abdomen. And why 24 weeks? Because the WHO has told that 24 weeks you can consider as a period of viability. So before 24 weeks, you will tell that it is, and it is adapted by us because we are a developing country. So we have adapted that 24 weeks is the period of gestation. So anything which occurs less than 24 weeks, we consider it to be an abortion. After 24 weeks, we consider it to be a viable pregnancy. So that's why it has to cross the period of viability and less than 37 weeks of gestation because it is preterm premature rupture of membranes. So if the leak occurs after 37 weeks of gestation, you will just call it as PROM, that is premature rupture of membranes. So this is the definition of PPROM. So it's a spontaneous rupture of membranes after the period of viability, that is 24 weeks of gestation, and before 37 weeks of gestation, and without any prior onset of true labor pain. So the first thing you have asked is whether she has any history of pain abdomen. She tells she doesn't have any other history. Next, you have to ask all other negative history to negate the risk factors of PPROM. So she's come with leaking per vagina. So you have to know why she had this symptom. So we have not yet confirmed by our clinical examination, but you have to ask the risk factors which would have been contributed to this PPROM. So what all you will ask? So one risk factor is vaginitis. So you should ask her what is the history, whether she has any history of white discharge per vagina. Next thing, what you want to ask whether there is any history of burning micturition or increased frequency of micturition because UTI is also one of the risk factor for PPROM. The third thing what you want to ask whether there is any history of bleeding per vagina because whenever there is PPROM, there is sudden decompression of the uterus. So whenever there is sudden decompression of uterus, the placenta might get separated and this might result in abruption of APH. So this could be one of the presenting symptoms. So you should also ask bleeding per vagina. And a very important thing you have to ask is the perception of fetal movements. So you have to ask whether she's perceiving fetal movements or not. Because if there is preterm premature rupture of membrane, sometimes there would be cord prolapse and fetal distress. So all these things could have been during presentation only. So you have to negate all this at the level of history. So each point is important, and for this you must know the risk factors which cause PPRM. So that's why your theoretical knowledge is equally important in your clinical case management. So once you have noted all these risk factors, now you have taken a clear cut antenatal history, that is first trimester history. In first trimester history, you have to ask any history of threatened miscarriage because threatened miscarriage is also a risk factor for PPRM. So you have to ask any first trimester bleeding or first trimester spotting. And in your second trimester, you have to ask any history of antepartum hemorrhage. So small bouts of antepartum hemorrhage also might end up and culminate into PPROM in her third trimester. So once you have taken a detailed history, then you will calculate her gestational age, past family and personal history. Then you will do a clinical examination. So what is important in clinical examination? We have to do a general physical examination. So you all know what is general physical examination. Then you will measure her vital signs. Why you have to measure her vital signs? Because you have to know whether she is gone into chorioamnionitis or not, because PPROM, one of the complication is chorioamnionitis, which has to be diagnosed and managed at the earliest. So you have to see whether there is any tachycardia, tachypnea, and whether you have to see whether she has any temperature, and history of fever also should have been asked. And you have to do a systemic examination and a detailed obstetric examination. In obstetric examination, inspection, palpation, and auscultation. So in inspection, the uterine height might be lower than the period of gestation because there is PPROM. Sometimes there would be oligohydramnios. So this thing you have to identify. Then you have to palpate the uterus and see whether she has got any uterine contractions. So the left palm of the clinician has to be placed on the fundus of the uterus and you have to palpate for contractions for minimum 10 minutes. So if there is any contraction, you have to know how many seconds is each contraction lasting for. So, for example, if she is gone into labor, she has some two contractions for 20 to 25 seconds. That means PPROM, she is gone into labor. But uterus is completely relaxed, then you can tell that she is not gone into labor. So, palpation for uterine activity is very much important. Then you will do all the grips. You will do first pelvic grip, second pelvic grip, and I hope as postgraduates, you know all this, and I need not tell it in detail. And you will confirm the presentation, whether it is cephalic presentation or breech presentation. Then you will do a speculum examination. Now, you finished your obstetric examination. A very important thing which should be done under to diagnose PPRO is to do a sterile speculum examination. So I will repeat. PPROM, the gold standard for diagnosis of PPROM is by doing a sterile speculum examination. So, why is it sterile? Because you have to wear a sterile gloves, you have to use the instruments which are autoclaved, and you cannot do and introduce infection because ascending infection might be a precursor for chorioamnionitis. So, you will do a sterile speculum examination. You will ask the mother to cough, and if you're seeing a gush of fluid which is coming out, then it's like a gold standard for PPROM. And you can also visualize the cervix, whether the os is open or closed. So based on this, you will know whether she's going into labor or she's just a case of PPROM. So I told you, you have to do only a speculum examination. You need not do a per vaginal examination. And when you do a speculum examination, take a vaginal swab and send it for culture and sensitivity. So you will take a high vaginal swab and cervical swab, and these swabs are sent for culture sensitivity because if there is any evidence of infection, you have to treat it because ascending infections might be the cause for chorioamnionitis. I hope I'm clear till now. So next is if there is no leak. So you have done the speculum examination, you can't see any leak. That time what will you do? So FDA has approved two important investigations. So the first investigation is called as actin partus. So what is actin partus? It is phosphorylated insulin growth factor binding protein. So why is this a marker for PPROM? So why is it a marker? Because this protein is present in the decidual surface. When the choriodecidual surface is interrupted or disrupted because of PPROM, this protein will be leaking and it will be there at the high vaginal swab you will take. So at that level, it will be because of the disruption of choriodecidual interface. So this is called as active partus. So it is a swab technique where it is also like a diagnostic marker for PPROM, and it just takes around 15 to 20 minutes. The second marker is called as placental alpha microglobulin, also called as PAMG1. So this kit is called as Amnisure kits. So these are also the swab kits which you take a swab and check, and the presence of protein will show you a marking. So this also is an indication for PPROM. So if there is gush of fluid, you need not do anything. This is the gold standard you have diagnosed. If there is no gush of fluid, there is no leak available. These are the two FDA proved. In literature, we had other tests like nitrogen tests. So you all know that the amniotic fluid is alkaline. So it will change yellow to blue will be changed in a nitrogen paper if you dip it in the amniotic fluid. So this nitrogen test and some things like looking for oligohydramnios on ultrasound, all these are past. So we don't practice now and they are not recommended by the current evidence. So the only things which are recommended is phosphorylated insulin-like growth factor binding protein, which is also called as actin partus. And the second thing which is recommended is PAMG1, which is also called as an amnesia kit. So you have diagnosed. Now, how will you go about it? So what will you do? So now you have finished your examination. No need to do a per vaginal examination. So I am stressing because Whenever we see a woman with leaking PV, you just want to do pervaginal and see two dilated, three dilated, one dilated, you want to tell. It is not necessary. Only if she's in labor, then you have to do pervaginal examination. Otherwise, you will not do a pervaginal examination if there is a clear-cut PPROM and she is not in labor and you have not found any evidence of chorioamnionitis. Now you might ask me, Madam, how do you diagnose chorioamnionitis? Now this patient has come, I want to rule out chorioamnionitis. So chorioamnionitis are diagnosed not by a single criteria. They have all the combined criteria. So this woman has come and next you have to send some investigations to rule out chorioamnionitis. So what are the investigations you want to send? You will send a CBC because there is a total leukocyte count which might be elevated in cases of choreo. The second thing which you want to send is a CRP, that is C-reactive protein. So this is also an inflammatory marker which might be elevated in cases of chorioamnionitis. So these two you will send. Even if these two are positive, you cannot tell that she is in chorioamnionitis because chorioamnionitis is a diagnosis of combination of clinical assessment, laboratory investigations, and fetal status. So, what all things are the positive markers of chorioamnionitis? First, clinically, she has to have pain abdomen, abnormal vaginal discharge, fever, and pain abdomen. So, pain abdomen, fever, abnormal vaginal discharge, and also decreased perception of fetal movement. So, these are all clinical criteria. The second thing is the laboratory criteria, where there is elevated leukocyte count and there is elevated C-reactive protein. And the third one is you have auscultated for the FHR. There is either fetal tachycardia or bradycardia. So, in combination for all these criteria, you will diagnose chorioamnionitis. It's a diagnosis of combination of different criteria and not a single criteria. She doesn't have any clinical symptoms, no signs. She just has raised CRP 6. You need not do anything. You can just wait and watch. So because PPROM, and if you terminate the pregnancy, you are giving a preterm baby to the mother, and you know preterm birth has lot many complications to the fetus, not only during that period, even it has long term complications in the adult life also. So you do not want to give a preterm baby, you just want to prolong the pregnancy. Until when you want to prolong is the question. So then comes the doubt, till when you can continue, and if I want to continue, how do I go about it? So that is called as expectant management of PPROM. So firstly, I will tell what are the contraindications where you have to immediately address the patient and terminate. So first we'll deal about the contraindications. Once you're clear about it, then we can go and think about what to do in an expected management. So first contraindication, obviously, if she is in established preterm labor. Second contraindication, if she is already diagnosed with chorioamnionitis. Third contraindication, if there is any evidence of fetal distress. Fourth contraindication, if there is any evidence of antepartum hemorrhage or abruption as such. And what is the fifth contraindication? Or sixth contraindication, where there is any cord prolapse, where you have to immediately take her up for a cesarean section. So these are all different contraindications for expected management. I would like to repeat. First, established preterm labor. Second, when the patient has gone into chorioamnionitis. Third, when there is any evidence of abruption or any evidence of fetal distress or any evidence of cord prolapse. So all these are different contraindications of PPROM, of expectant management of PPROM. So now, if all these are negated, it's just a clear-cut case of PPROM. She's not in labor, not in chorioamnionitis. Next, what do I do, madam? How do I manage? So this lady, which I gave a case scenario, is 29 weaker. So what do you want to do with her? So you have sent her for CRP and total leukocyte count. Everything is normal. Should you give antibiotics? Should you give corticosteroids? Should you give magnesium sulfate for neuroprotection? Do you want to keep her in the hospital or send her home? Is all the different management questions. So first thing, antibiotics. It's definitely a yes, because PPROM, there could be ascending infection. So you have to give antibiotics. So what antibiotic is recommended by GTG? So there is a GTG, that is Green Top Guideline for PPROM. It is 67th GTG. So they tell give tablet erythromycin 250 milligram QID, that is 4 times in a day, every 6th hourly for 10 days. Or if she goes into established labor, till then. So whichever is shorter, till then you give. So I will repeat, tablet erythromycin 250 milligram QID for 10 days till she goes into established labor, or 10 days. Whichever is shorter, you have to give that course of antibiotic. So this antibiotic has to be given. The second thing is corticosteroids. What do you need to give, corticosteroids or not? So I would like to highlight about two important terms which is constantly repeated in all GTGs or RCOG guidelines, is offer and consider. Offer means you have to give irrespective of anything. It's like just give, don't think, just close your eyes and give. Consider it is upon the discretion of the clinician. I want to give, I will give. My colleague doesn't want to give, she doesn't give. So it is the clinician's discretion and not an individual, and it's not a complete recommendation. You can give for the benefit, you can take your call. So that is considered. So corticosteroid should be given from 24 weeks of gestation till 33 plus 6 weeks of gestation. So offer corticosteroids between 24 weeks of gestation till 33 plus 6 weeks of gestation. Consider giving antenatal corticosteroids from 34 weeks till 35 plus 6 weeks of gestation. So this is the recommendation. What corticosteroids to give, when to give, why to give, that is a other topic for discussion. Third point, should you give magnesium sulfate for neuroprotection? So when should magnesium sulfate be given? So if she will deliver, or you're anticipating that she will deliver within 24 hours, you have to give a magnesium sulfate neuroprotection, which is important, and that is given, and you have to offer magnesium sulfate between 24 weeks till 30 weeks. You can consider magnesium sulfate from 30 weeks to 34 weeks. Okay. So this is about magnesium sulfate for neuroprotection. The fourth thing is, do you want to keep her in hospital? So she's the 29 weeks. So till when do you have to wait? And when do you have to do this expected management? So I tell, I will not keep her in hospital, and I will see her accessibility to the hospital. So expectant management, whether you can do it in the hospital or an outpatient basis, is depending on different factors. So what are these factors? So first, the patient's preference. You have to ask her whether you will stay in the hospital for so many weeks, or you will go and regularly visit the hospital, and the distance of her home to the hospital, and then other clinical and biochemical criteria. If CRP is increasing, she has fever, all these, then you have to see whether she's going into full-blown chorioamnionitis or she is not going. So for that, you need observation. You cannot send her home. So based on that, and you have to also think about whether there was any history of preterm labor, any history of PPROM. So all these also have to be asked to do an inpatient basis care or to send her home. Okay. So if you want to send her home, you have to ask her to come back for review. So when you can either ask her to come weekly once or bi-weekly once. So once she comes, what all you want to see? Firstly, you have to ask her for any history of those symptoms which I told for choreo. You have to ask her whether she has any pain abdomen. You have to ask and get a CBC, that is for the leukocyte count, and CRP, and you have to auscultate for FHR and to see the fetal status. So if everything is normal, weekly reviews you can continue till 37 weeks of gestation. So till 37 weeks of gestation, you can do an expectant management, and at 37 weeks of gestation, you can terminate her pregnancy based on her clinical condition. So this is how we go about an expectant management. And PPROM, if she's already gone into labor, you have to other discuss the gestational age and whether to do a vaginal delivery or a cesarean section based on a gestational age and the neonatal ICU which is available in that specific unit. So this is how you manage PPROM. So certain things like amnio infusion, all these are not recommended in PPROM and they are not evidence based. So this things completes how you manage a case of PPROM. So what history you will take, what are the risk factors and negative history you will elicit, what examination you want to do, and a sterile speculum examination is a gold standard. How will you manage a case of PPROM? How will you do an expected management? When you will consider chorioamnionitis and when you will deliver her. So this is the first session, or these are the type of sessions where we'll be discussing a problem-based learning or a case-based discussion. So any doubts in this? If you have any doubts in PPROM, you can ask me, you can unmute and ask. If
Ma'am, as you said,
not able to hear, you can drop it on your chat
the,
box.
the
I'm I'm not able to hear you. Someone who had a query and any doubt, can you please repeat?
can you hear me now, ma'am?
Yes.
I was asking, like you said, amnio infusion is not recommended. What I have seen in my hospital, in all cases of PPROM, we start antibiotics and we put the patient on some or the other kind of hydration therapy. They give aluminum infusion and they put them on multivitamin capsules. Does that have any bearing on the outcome?
See, it is like a supportive therapy. So, hydrotherapy, because she has an ongoing leak, you can advise her hydrotherapy if there is any evidence of oligohydramnios. And so, hydration is always better if taken orally. It is not recommended you do an amnio infusion. Amnio infusion is such that you keep a IV set inside the cervix and you infuse normal saline. So, this is mainly to compress the cord and to prevent cord prolapse. So, this is amnio infusion. That is not recommended and it is clearly contraindicated. But what is recommended is hydration therapy. But the present evidence says that there is no requirement of something called as Hermin infusion. All these amino acid infusions are not recommended according to present evidence. But these arginine tablets, which we usually give arginine sachets, so arginine is a precursor for nitric oxide. So the main mechanism why you are giving L-arginine sachets for the patient with oligohydramnios is the arginine amino acid is a precursor for nitric oxide. So this nitric oxide causes vasodilation, increases the blood supply to the baby. Because there is increase in blood supply, the renal blood supply also increases. The fetus will produce good amount of urine, and this urine only is nothing but amniotic fluid in second trimester, third trimester. So this present evidence says that we can give these arginine sachets, but there is no evidence to give amnio infusion for PPROM. I hope. And hydration is a supportive management. It's not that you admit her and continuously put IV fluids. You can ask her to take adequate amount of water at home also. So 4 liters of water if she takes, that is also a route of hydration. It is not only IV fluids which are recommended. I hope I cleared your doubt. Is your doubt clear,
Yes,
ma'am?
ma'am.
Okay. So, should
Yes,
we
ma'am.
go to the next topic? So, next topic, as I was telling, magnesium sulfate and neuroprotection. So, what is magnesium sulfate? Why is it given for neuroprotection? So, this is like a topic which is lecture based, which is more of theoretical, which has some clinical application in your day to day life. So, how many of you tell magnesium sulfate is to be given as a neuroprotective agent? All of you want to give magnesium sulfate as a neuroprotective agent?
No, ma'am. For this case, because she is not in any preterm labor per se, so we don't
Not
have to
like
start.
not in this case. In general, do you want to give magnesium sulfate?
Ma'am, are you asking routinely or?
Yeah, routinely in a routine case, not in my previous case. That case discussion is over. Now, this is a lecture-based discussion where we will learn the importance of magnesium sulfate as a neuroprotective agent. So, is it important for us to give magnesium sulfate, or it is okay which we need not give magnesium sulfate?
We need not routinely. We need not give it unless we expect a
Unless,
preterm. Unless we expect a preterm delivery, we
okay.
need
So,
not.
in when we are expecting a preterm labor, why do you need magnesium sulfate?
Because fetal cerebral anoxia, hypoxia may be there.
Hmm.
So to
How
reduce
does
the chance of,
magnesium sulfate negate the fetal hypoxia?
not directly, but it could help prevent cerebral palsies and other things.
Yeah, so that is the evidence. So now I will tell you under these headings. So we'll discuss why magnesium sulfate is acting like a neuroprotective agent. So these are the headings which I would like cover. So see you in my routine hospital, you would have been giving magnesium sulfate is given, which regimen is given, Zuspan regimen is given, they will tell, but you have to never tell Zuspan regimen is given for magnesium sulfate. You have to tell that magnesium sulfate is given as an IV regimen for neuroprotection. You can't use the word Zuspan because Zuspan regimen is given in preeclampsia. The same you can, though the components of the regimen is same, you cannot tell Zuspan regimen. You have to elaborate and tell how it is given. So, firstly, why should it be given? So everyone agreed with me that it should be given in cases of imminent preterm labor. So why it should be given? How does it prevent cerebral palsy? When it should be given? That means at what gestational age? Which regimen is most ideal? What are the side effects of magnesium sulfate? And is it if efficacious? And if yes, in what subgroups is it efficacious? So we will discuss the role of magnesium sulfate as neuroprotective agent. Firstly, why we have to give magnesium sulfate. So the first thing is we have to give magnesium sulfate because it prevents cerebral palsy. So this is our background UG knowledge. So come, let's grow and we will learn more about magnesium sulfate with our PG knowledge now. So why? Because the recent Cochrane evidence says that it prevents cerebral palsy and the relative risk comes down to 0.68%. And it also prevents the fetal death after delivery along with prevention of cerebral palsy. And in general, it will decrease the gross motor dysfunction of the baby. So preterm babies have lot of cerebral hypoxia and anoxia because of excitatory stimulus. So there is something called as NMDA receptors. So these NMDA receptors are present in the oligodendrocytes in the fetal brain. Okay. So what is this NMDA receptor? So it will be a channel like this. So there will be glutamates in the presynaptic membrane. This glutamate will transfer through the NMDA receptors and reach the postsynaptic neuron. So in the neuron, in the synapse. So what happens whenever the glutamate is entering the NMDA receptors, there is too much of excitation which is happening at the level of the neurons. So this is called as excitotoxicity. So this excitotoxicity is mainly the reason for the hypoxic and ischemic damage to these neurons, which in turn give rise to gross motor dysfunction and cerebral palsy in the later life. So what does this NMDA receptor, so what does this magnesium sulfate do? This goes and blocks the NMDA receptors. So this is how it prevents cerebral palsy. So now we have understood why it prevents cerebral palsy. That is more important. So I also emphasize PG is knowing about why. So it's given as a neuroprotective agent. Yes, all agree. But why? Because this is the main reason, and this excitotoxicity, and there is increase in free radicals also. This free radicals cause the damage to the neurons. So these neurons which are present in the forebrain, which might be a precursor problem for a cerebral palsy. So this magnesium sulfate has different mechanisms of action. The first thing is antagonizing the NMDA receptors at the level of the oligodendrocytes in the forebrain. Second is stabilize basement membrane. So it stabilizes the basement membrane in the neurons. So when it stabilizes, there is decreased entry of free radicals. So antioxidant properties also it will elicit. So that's important second mechanism of action. The third mechanism is it will decrease the inflammation also by decreasing the pro-inflammatory cytokines. So this also reduces the inflammatory and ischemic damage to the neurons. And the fourth important, as you all know, magnesium sulfate is a vasodilator. So it increases the cerebral blood flow to the baby. So that also prevents the ischemic damage as the blood flow to the brain increases. So these are different mechanism of actions of magnesium sulfate. So it has a neuroprotection role in cases of preterm fetuses. So this is how magnesium sulfate causes neuroprotection. Next, when should be it given? So the first thing, as she rightly told, that it should be given only when we are anticipating a delivery within 24 hours. So when you are anticipating preterm labor within 24 hours, then you are giving magnesium sulfate. So then, okay, she's already 8 dilated. Should I give magnesium sulfate now? One of my postgraduate will ask me. She's 30 weeks of gestation. You told magnesium sulfate is good for neuroprotection. Should I give magnesium sulfate? I will tell she's already 8 to 9 dilate. You can consider giving magnesium sulfate. So what is the minimum interval which is required for giving magnesium sulfate is 4 hours. Why 4 hours? Does anyone know why there should be at least 4 hours for giving magnesium sulfate to cause neuroprotection?
Something to do with half-life of magnesium.
No, it is not about the half-life. It is not about the half-life. So it is mainly because the magnesium sulfate, you're giving it to the mother. So it should go to the fetus, reach the fetus, cross the fetal blood-brain barrier, reach the fetal forebrain, and then exert some action. So it at least takes, after magnesium sulfate infusion, when you give the loading dose, it will take minimum 2 hours for reaching the fetal plasma. From the fetal plasma to cross the blood-brain barrier, it takes about 4 hours. So to cross the blood-brain barrier, reach the target. Our target is the forebrain. And this forebrain is rich in the oligodendrocytes, which are preventing gross motor dysfunction. So there it is, to go and act there, it minimum takes 4 hours. So that is why we have to offer magnesium sulfate when there is at least 4 hours interval of her delivery. But even if 4 hours is not there, you can still consider giving magnesium sulfate because some amount of benefit might be there. So that is about why 4 hours and within 24 hours. So you're planning a elective preterm birth. So she's a case of severe preeclampsia. She's a case of severe IUGR with Doppler changes, or she's gone into HELP. You have to deliver her and she's just 30 weeks or 29 weeks. You have to immediately give because you're doing an elective preterm induction. So in these cases also, or if the patient is already in spontaneous preterm labor and you're anticipating her delivery within the 24 hours, you can still give. Then you might ask me, madam, you have given, but she did not deliver. What will happen? Nothing will happen. So it will not cause any long-term side effects to the fetus. So it is always better. So the risk versus benefit ratio will confer that magnesium sulfate should be given what period of gestation. So according to RCOG, you have to offer magnesium sulfate from 24 weeks till 29 plus 6 weeks, that is 30 weeks of gestation. You can consider giving magnesium sulfate between 30 to 34 weeks of gestation because the early preterm labor and very low birth weight babies are at a higher risk of cerebral palsy. So as the gestational age is less, the risk of cerebral palsy increases. As the gestational age increases, the risk of cerebral palsy decreases. So that you have to definitely give if the gestational age is less than 30, and you can consider based on the weight and whatever to give after 30 to 34 weeks. After 34 weeks, you need not give because the fetus has the capability to manage that oxidative stress. So that is when to give magnesium sulfate. So these are the situations where it is recommended. Next, which regimen? So when they were starting these trials and meta-analysis, they used to give a loading dose of 6 gram or a loading dose of 4 gram, and then the maintenance dose of 1 gram per hour IV infusion for 24 hours. So they have to give 4 gram loading dose for 15 to 20 minutes. It should be an IV loading bolus dose, 4 gram, which is given over a period of 20 to 30 minutes max. And then 1 gram per hour infusion for 24 hours. If she delivers by 12 hours, just stop. So till 24 hours or her delivery, whichever is sooner, you give till then. So this is the regimen to be followed for magnesium sulfate as a neuroprotection agent. What are the side effects? So you have to know that there are common side effects because it's a vasodilator. The patient might have flushing, palpitations, nausea, vomiting, and sometimes she might have slight discomfort at the cannula site. So all these are common side effects. It does not cause any major side effect. But as you all know, we have to definitely monitor for magnesium toxicity. So this is very important. So usually when you're giving it for eclampsia or impending eclampsia, also you're monitoring for magnesium because this magnesium sulfate, if given at a higher dose or if it goes for magnesium toxicity, she might go into arrhythmias and cardiac arrest also. That's why it is very important for us to monitor when we are giving magnesium sulfate. So what are the very important 3 parameters which have to be kept in mind? First thing, respiratory rate. Second thing, urine output. Third thing is the deep tendon reflexes. So deep tendon reflexes is the first one to get altered if there is the therapeutic index of magnesium sulfate increases more than 7 milliequivalent per ml. So that's why you have to see whether it is present or not. So every 4th hourly, you will check for deep tendon reflexes. You will check if her respiratory rate is more than 12 cycles per minute and her saturation should be more than 95% and her urine output should be at least 30 ml per hour, accounting for those 4 hours, at least 100 ml in those last 4 hours. So this monitoring for toxicity is really important when you're administering magnesium sulfate. So if you're giving these and if her deep tendon reflex is absent, just stop magnesium sulfate and you have to have right away, you have to have in hand calcium gluconate and you have to remember something called as the rule of 10. 10 ml of 10% of calcium gluconate is given over 10 minutes. So this is an antidote for magnesium sulfate. So magnesium sulfate the toxicity can be reversed by giving calcium gluconate. So these are the management. How do you manage magnesium sulfate toxicity? Next, madam, is it efficacious in all conditions, whether you give an induced preterm labor, or you give in spontaneous preterm labor, or when you're giving in preeclampsia, or when you're giving it PPROM, is it useful? Irrespective of the subpopulation you're giving, magnesium sulfate is always useful. You have to remember that there is so much of stress within the fetal brain, which leads to hypoxic and ischemic damage, which leads to cerebral palsy. And it accounts, cerebral palsy is around 7 to 8% common if there is the gestational age is less than 30%. 30 weeks of gestation. So that's why it's very important for us as clinicians to administer magnesium sulfate if the patient is going into impending preterm birth within 30 weeks. It should be offered 30 to 34 weeks, it can considered. So these are the very important points which you have to be remembering when administering magnesium sulfate. So this is a theory topic of discussion. Why magnesium sulfate should be given? What is the mechanism? When it should be given? What regimen? So all this is theory. But still, this is very important as it has a clinical application in your day-to-day life. So that's how you have to know each and everything when you're dealing with a problem. It's not like, yes, magnesium sulfate is given for neuroprotection. It's not like that. You have to know why is it given, why you have to administer within 24 weeks, when I should administer. So these questions you have to think by yourself and get the answers. So if you have a thorough knowledge about the subject, then definitely you will be able to answer all these points. So this is about magnesium sulfate. So anyone has any doubts, or can we go to the last topic of discussion?
Ma'am, I have a doubt. Suppose we've given magnesium sulfate to a patient and she has not delivered. Is there a need for repeating the dose?
No,
Or
no
if
need.
so, okay.
So if, for example, you have given magnesium sulfate and you have completed the dose, there is no consensus to repeat the dose of magnesium sulfate if she is not delivered. So if she is progressing, you need not repeat. So it has caused enough result. So you need not repeat. Okay. So the repeat courses of magnesium sulfate for neuroprotection is not necessary. But it does not cause any undue harm also if she doesn't deliver. You have given, but she is not delivered, it is okay. Long-term consequences have not been proved yet, but we don't know in future. There could be some long-term complications, but present consensus tells that there is no long-term complications. I hope you have understood. Okay. So the last topic of discussion for today, it's a practical case discussion. So how do we deal in a practical case examination? So you will, in your final exams, in your practicals, you will get a gynec case, you will get an obstetric case. In some institutions, there is a long case, short case for both obstetrics and gynecology. So you have to know each importance when you're going and dealing about a case discussion. So this is like a case discussion which will be there for your final exam. So this short course is just for practical examinations. It's not for theory, but it's just those important cases which will the most repeated cases in your practical examinations. I will be dealing in detail. But today I am not dealing the entire case of postmenopausal bleeding. I'm just giving you an example that how we will take the discussion forward. So for example, a woman, a 69-year-old has come with to your OPD with just postmenopausal woman. She tells she attained menopause 15 years back. So this is your small bit of case which you have got to your routine gynec OPD. So how do you go about? So immediately when she comes with postmenopausal bleeding, it is not that she has got endometrial carcinoma. It does not mean that she has got endometrial hyperplasia. So how do you arrive at a diagnosis? So what is important that I am going to just tell you in brief for about 10 minutes and we'll end the session. So firstly, if a woman comes with some symptom, the socio-demographic factors are equally important. So you have to know what is the importance of name. You have to know what is the importance of age. She's 69 years. So in this 69 years, which of the conditions are more common? She might have prolapse with a decubitus ulcer, which is causing the postmenopausal bleeding. Or she might have got endometrial carcinoma, which is leading to postmenopausal bleeding, or it's nothing, it's just the atrophic endometritis which is causing some bleeding. So the age group is so important that all our differential diagnosis from of top one to last will depend upon the age group she belongs to. So all the socio-demographic factors are equally important in coming to a diagnosis. So today when I was taking UG class, I was telling them the importance of history, because by the end of history, you will be able to come to a provisional diagnosis. If she comes with postmenopausal bleeding, you cannot tell, go get ultrasound done. Yes, ultrasound is a component for diagnosis of PMB, but it is not the right away choice. You have to know what is the history, what she's come with. So she has prolapse with decubitus ulcer. What you will find in ultrasound? It is of no use. You will do MRI. What is the use? You will do PET. So as clinicians, what I want to emphasize is history taking is equally important, not only for exam point of view. It is important in your daily practice also. So as a clinician, I'm telling you daily a brief history. I can't sit and ask, okay, what diet, morning you had idli, afternoon you had dosa, full diet history I can't take. But important history for that case is really important. So if she's come with postmenopausal bleeding, I have to ask her all the socio-demographic factors. I have to ask how many episodes of postmenopausal bleeding. Each episode lasted for how many days? Did she use any pads? Whether there was only spotting, whether there was bleeding, whether she had any pain abdomen. Is there any mass per vagina to rule out prolapse? Is there any mass per abdomen to see whether there are any ovarian tumors? Or if there is any other symptoms like loss of weight, loss of appetite, which might be common in carcinoma. So all these, and I have to ask her whether she is taking any HRT, because exogenous hormonal intake also could be a reason for for postmenopausal bleeding. So thorough history taking, and when I do a session, I will be emphasizing on each and every parameter in the entire case, which is important for arriving at a end diagnosis. Then a detailed examination. What is the importance of checking pallor, whether she's significantly lost? So if it's a case of CA cervix, sometimes they would have acute bleeding. So there is a postcoital bleeding which was acute and she's anemic, she's cachexic. Her general physical examination, you see her, you just go and ask her to lie down in position. There'll be foul smelling discharge, and you can feel the smell when you go near her only. So these parameters are very important to arrive at a final diagnosis. So the importance of GP, systemic examination, then you have to do a parabdomen examination to see any mass is palpable, very inguinal nodes are palpable. So all thorough examination, then you will do a speculum and bimanual examination. And if there is prolapse, you will see decubitus ulcer, which is bleeding. If there is CA cervix, you will see the growth, or if you will see any ulcerative lesion around the cervix. And you can diagnose so many things at the level of history and examination. So when you come to a diagnosis, you might not know what is the diagnosis. So atrophic changes are present around the wall. So it could be atrophic vaginitis also. So sometimes you will not be able to tell one single provisional diagnosis. You will arrive at a differential diagnosis. So what are the differential diagnoses in postmenopausal bleeding? So it is not always carcinoma. Yes, endometrial carcinoma is a very important thing to rule out when she's come with postmenopausal bleeding. So if she comes with postmenopausal bleeding, I cannot just tell, oh, your age is 70, you have atrophic vaginitis, you go enough. And I cannot tell like that, because you have to always evaluate for endometrial carcinoma, and you have to rule out that and then reassure the woman and send her home. So without evaluation, you cannot send her. So what I will do for evaluation? So firstly, what are the differential diagnoses? So if you go back to theory, around 60 to 80% of postmenopausal bleeding is due to atrophic vaginitis, atrophic endometritis. So what happens due to hypoestrogenism? The endometrium will go into atrophy, the vaginal walls will go into atrophy, and there may be some amount of friction, the dryness, which might cause postmenopausal bleeding. So this is the most common diagnosis, or the most common cause for postmenopausal bleeding. The second, if she's taking any hormonal treatment, that could also be around 15 to 20% due to exogenous hormone intake. Third, if there are any local lesions like a small cervical polyp, small endometrial polyp, the decubitus ulcer on a prolapse uterus. So these are all local causes which also compute around 10 to 15%. Endometrial hyperplasia. So this could be around 10%. It might contribute PMB. Endometrial carcinoma also corresponds to around 10% of PMB. Cervical cancer also can present to you with postmenopausal bleeding, and it is less than 1%. So these are a differential diagnosis you have to keep in mind when a case comes with PMB. And what do you want to do? You have to just do all the examination, what I told. Do an ultrasound examination. Why you're doing ultrasound? To see the thickness of the endometrium. So this is very important to rule out hyperplasia and carcinoma. So according to FIGO, we have the cutoff is 4 mm. According to ultrasound criteria, they give the cutoff is 5 mm, but we follow FIGO guidelines. So 4 mm it should be. So less than 4 mm, you just can reassure her, but also keep in mind 4% of endometrial cancer can also occur if the endometrium is less than 4 mm. So my personal practice is, irrespective of the lining or irrespective of the thickness which is measured on ultrasound, I do an endometrial biopsy to to negate endometrial carcinoma and hyperplasia and to be on a safer side, because less than 4%, 4 mm I am not doing. What if she ends up in carcinoma endometrium after 2-3 years? Because less than 4% or 4 mm also, there is 4% chance, that is 100 women, in 100 women 4 people might have endometrial carcinoma, even the thickness is less than 4 mm. So we do not want to take a chance. So endometrial biopsy is a simple OPD procedure which you can do. But guidelines say it's always better to do a hysteroscopy guided biopsy or a fractional curettage. What do you mean by fractional curettage? So fractional curettage is doing an endocervical curettage followed by an endometrial curettage. So this is called as fractional. Previously, they used to do in 8 different sites: fundus, cornua, anterior wall, posterior wall, and the endocervical. But now we do not have the traditional fractional curettage. We do something called as a modified fractional curettage. It has only 2 samples. One is endocervical sample. The second one is endometrial sample. So once you have negated endometrial hyperplasia and carcinoma, you can send her home by giving vaginal estrogen supplements if she is a case of atopic vaginitis. So this is how you come to a diagnosis, or you arrive at a differential diagnosis and you do the evaluation. And once you have done and come to a final diagnosis, you manage. So this is a picture which I have just put from a guideline, that is GTG. I think it is 73. So this is a management of endometrial hyperplasia. When I was PG, all my carcinomas, everything I read from Berek and Novak's. So that time I was not very familiar of GTGs. I used to see, but not everything. But now, as I've finished my part to MRCOG, I know which to take from where. So if you ask me, Madam, where to study endometrial hyperplasia, I'll tell, read Novak's and read GTG number 73, because it has given clearly when you have to do hysterectomy, when you have to insert Mirena, when you can give oral progestogens, and if she is not completed her family, how to go about. So it is very crystal clear. This case, what I have to do, there is no confusion. Okay, if you ask me, Madam, where should I read vaginal birth after cesarean section, I will tell, go read ACOG guidelines, because that is given better when compared to RCOG. So it's not like, oh, so many guidelines, which should I follow? Should I read textbook? Should I read guidelines? It's not like that. You have to read what is applicable in your country with your patients, which is more relatable. So that should be studied. Okay. So that I will be emphasizing. So if you ask me, Madam, where should I read Doppler? For the basic, to read Doppler in obstetrics, read Ion Donald. If you want in depth, read Gabe for clinical application, both in Rh negative pregnancy and FGR. If you still want to go and read about practical application of Doppler in obstetrics, go read Callens. It is a separate book for ultrasound and Doppler. So it is, everything is very crystal clear. You need not have a confusion in mind. There is so many things what to read. So you have to know what to read from where, because it's not like you can read everything. You have to know which topic is given where beautifully, and that if you read, it will be good. So what do I suggest? See, if you enroll to this course, I will not be discussing all the 20 books of obstetrics and gynecology, but I will definitely ensure that I will discuss all the must know topics, the good to know and nice to know. You have to go back to your textbooks. I'm a strong believer of reading textbooks, because what I have done during my PG period is read all the textbooks, read some guidelines, make notes, and read that. So that is what which I had done 7 years, not 7 years, 4 5 years back. So now what I recommend is, you enroll to my course or other course or whatever, you don't enroll to any course. I am a strong believer to read textbooks. If you tell no, ma'am, I don't have time, make some time, because if you make time, your foundation will be too good, and this will help you for your clinical practice and for your career ahead. So I might have been doing infertility practice now. That doesn't mean I don't know how to manage a GDM case. I will be ashamed if I don't know how to manage a GDM case who has come with a sugars of 200 or 250. I should know how to give insulin. So it is the basic etiquette or the basic responsibility of being an obstetrician or a gynecologist to manage a case which has come to your OPD. It's not like you do some super specialty and you leave all the basics. It's never like that. Till day, I am a strong believer of reading textbooks and approaching each case with evidence base. So that is my take home message. So that was the session today where I had a brief lecture and a practical case scenario and a case based learning. So, anyone has any doubts regarding these three topics, you might ask now. Otherwise, we'll end this session, and I'm also telling that I would like to start my course in the next week, might be around Thursday or Friday, that is 24th, 25th. I plan to start on 25th, which will be my first class of the course. So I would encourage enrollments only till 23rd, that is Wednesday of next week. So by then, if you enroll, I would create a group and I will be sharing the first schedule, so that, because I want to finish the long course by September end, because many of them have exams in October. So I do not want to prolong. So I just want to not rush through during the last months. I wanted to be very systematic and scheduled. So that's why I will be encouraging enrollments till Wednesday, and Thursday will be a break day, and we'll create group and share all the schedules and the learning material. And from Friday or Saturday, I can start the course with my first session. Do anyone have any other questions relating to the course or the topics which I discussed? You can message me on chat box also. Recording, okay. Ma'am, can you please share the notes you're going to tell in each class? See, sharing notes. So whenever I am speaking to you, I will repeat multiple times so that you can make notes. And I know Gynae is a very busy branch. You have labor room postings, you have OT, you have night duties. And if you're not able to attend, I want to send the recording only which is has an access for 1 week. Why 1 week, ma'am? If you ask me, because this 1 week will motivate you to go back and read the or watch the recording and make notes. If I keep a long access, I know I am very sure people will just postpone. So I am proudly telling the students who are enrolling, apart from my PS postgraduates, they're all my students, but apart from that, in this course, whoever is enrolling, I want to consider you as my personal students. It's not like you just watch and forget. It's not like that. You will have that one-to-one contact with me. And by the end of your curriculum or by the end of your PG course, if you have passed with flying colors or if you gain some knowledge from this course, I would be the most happiest person, and I will be sharing your joys at the end of your course or the end of post graduation. So I want to be that. I don't want to be a normal video which you watch on YouTube where you just go. If you want, you will watch. You will be distracted. You will be watching mobile, or you will get into other works. You will go back to your PG life. That is not the case. The main motto of this session or this course is to ensure that you go back and finish your timetable, finish that topic which is designated for that particular week. So you will be getting the recording to your direct email, and which is accessible for a limited time, that is 1 week. So that recording facility, I will send it to you. So you need not worry. If you have missed the live class also, you can go back and see the class in your email for that 1 week time. And I am sure in 1 week you will get at least 1-2 hours to go back, go and see the recording. So that much I am sure. So that was one question. Okay. So those are the questions on the chat box. Do anyone have any other issues? Is my voice clear? And the lighting, everything is clear. And in my further lectures, I will also write and explain certain things. So I'll be using a whiteboard also for other flow charts and discussions and diagrams. So this, as it was a demo class, it's just the slides and my presentation. But in the course as such, I will be using the whiteboard frequently for better understanding. But learning material as such, I will not be providing any notes, but I will be giving you all the guidelines and the unaccessible guidelines for you. I have downloaded it for my MRCOG purpose. So those, and what topic to read from which books, where is it given better, that information I will definitely share it with you on your WhatsApp group. So that is for today. Thank you all for joining. Really happy to see you people. So if there are no many queries, we will end the session. And this session will be available on YouTube. I will share it on YouTube. So you all have my personal number. You can share it with your friends or other your respective postgraduates. And enrollments will be till 23rd of April. And the class sessions will be starting from 25th or 26th. So no other queries. So this recording of demo video will be available on YouTube, and you can share it with your friends and postgraduates. So I'm very happy for this successful demo session. Thank you all. Happy learning. So these are my contact details. You can take if you do not have it. Thank you.